All right, looks like we're live on Facebook and we're live on YouTube. Good morning, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gateway to Health. Today we're talking about Debarquement Syndrome. We're going to call it MdDS just to make it easier for the discussion. And we're joined by Kathy. Good morning, Kathy.
Good morning, everyone.
And everybody is joining on, saying good morning and good morning to everyone. Hopefully you're all having a nice Saturday. So we're talking about MdDS per the request of one of the listeners. So I thought it's good that we talk about it. I don't think that we've really talked about this subject. Have we, Kathy, that you can recall?
No, we've talked a lot about its cousins, but we've not really brought this one up. So this will kind of loop us in and tie everything together, I think, on this.
Yeah, I think so too. I think this will be fun. And even though MdDS is not extremely common, some of you may know someone with MdDS. These are individuals that basically all of a sudden start feeling like they're moving or that they're rocking or that they're bobbing back and forth. And most commonly, people will associate it with airplane travel, being on a boat, going on a car ride where you're going around, these turns and somebody's driving too fast or something like that. But it can happen just seemingly out of the blue. It can just happen, quote unquote, spontaneously. So hopefully in today's discussion, if you know someone with MdDS or if you have MdDS, you'll have a lot better understanding of what's going on in the brain and how this really comes about. And any thoughts on your part, Kathy, relative to that?
No, not really. The question that I had here was talk about causes versus the spontaneous form.
Mm-hmm.
So they can actually just show up on its own.
I know, isn't that interesting? And I've seen cases like that too, and I kind of scratch my head because trying to be diagnostically specific, you would kind of want to think like, okay, they weren't on a boat when this all of a sudden came about. But it actually kind of makes sense in considering the underlying mechanisms as to how that would occur. And I will say, I think we're seeing some stuff kind of on the forefront, so to speak, working with patients that may not be in the literature yet. And maybe you'll see stuff in the literature about changes in the cerebellum, right down here at the base of the brain, as we use a brain model. You may see changes in the cerebellum from an anatomical standpoint, meaning volume, in the coming years. That's what I suspect. So what I'm trying to get at there, Kathy, is that for those spontaneous cases, I wonder, are these individuals who have an autoimmune attack against their cerebellum? And because,
okay,
yeah,
so a whole another attack there. Okay,
exactly, and that's probably what's leading to them feeling like they're moving. Yeah.
Okay.
Yeah.
Well, and we're all familiar. I mean, there are a lot of people that are familiar with being seasick.
Right.
Myself included.
Right.
We've had motion sickness.
Oh yeah.
I mean, we've been there. We know what that feels like.
Mm-hmm.
But usually when you leave the boat, yes, you may be deathly ill,
mm-hmm.
and you may still feel like you're moving for quite some time, but it goes away. But in the case of MdDS, that's not happening.
Exactly. That encapsulates it perfectly. So for any of you who have been motion sick, you've been on a boat and you throw up or you just feel awful, imagine feeling that way for more than a month. That's technically the diagnostic criteria for MdDS. If you have it for a month, it used to be 7 months, now it's a month. But can you imagine feeling that way just for weeks, months afterwards? You just always feel like you're rocking, always feel like you're sick, always nauseous. There's a heavy association between this disorder and fatigue. Why? Because you're basically activating the lower brainstem. And when we're motion sick, we tend to get nauseous, we're tired, we yawn a lot. It initiates a bunch of brainstem reflexes that cause us to feel that way, but it's not pleasant, to say the least.
No, I would think you would lose weight. I think there'd be a lot of repercussions to this because having been really seasick, and those who have been, when you're on the boat still, you want to jump off and drown yourself. So the thought of getting off of a boat and being that way for a month or more would be devastating to me because I've stayed off the boat, and I mean, you treated my vertigo. So to take care of that, I was able to get back on a boat, and since then we've bought 2 boats, but I would never have even dreamed of it had we not worked together and taken care of the vertigo that I had but that's a lot different than what we're talking about today. This is an ongoing thing and not really vertigo.
It's not really vertigo. Vertigo technically has to be the illusion of motion, typically of the world spinning around us. In this situation, there's the illusion of motion, but it's more that the person feels that they're moving or that they're bobbing. Sometimes they'll have the appreciation that, you know, the world is kind of moving around them like this too. But yeah, this is a little different than true vertigo.
And not just a boat for truck drivers, people who drive across country, which you know I do several times a year.
Yeah.
You drive for 12 hours in a day's time, get out, you're worse than you've been on a boat. You're swaying all over the place, and when you lay down your head at night, you're still swaying all over. So, yeah, there are different things. Don't folks think you're going to get off a boat or an airplane and have this. This can be caused by different occurrences. So, I find it interesting that it can go on this long, and I'm hoping you're going to tell us why.
And I've even had the instance of, you know, being in the water, being in the waves. I didn't have it longer than a month, but I had it for about a week where I just kept feeling like I was moving. It was really odd. But that was before my cerebellum was addressed. And as you know, I had motion sickness that was really bad. I had trouble flying. Thankfully, through this type of work, now I can fly without any significant issue. So your cerebellum every week, and your cerebellum can be rehabbed. It can. So that's what we're going to talk about. So what was the next question? Should we go right into that, or was there anything else?
Talk about tilt versus translation in the velocity storage mechanism.
Okay, my favorite subject. So your brain here, and then you have your inner ear, which is down at the base of your skull. And your inner ear has 3 semicircular canals. So I was going to try and make a model this morning, but I think most of you can kind of appreciate it. Think of, what is that stuff? It has like felt, but it's a wire with, it has like felt around it, and little kids use them. They're like little twisty ties. So if you took 3, you know what I'm talking about?
Pipe cleaners.
Yeah, the pipe cleaners. So if you took 3 of those and you angled them basically at 90-degree angles relative to each other, and you have one facing kind of anterior and forward laterally, you have one kind of going back like this, and then you have one in the horizontal plane, that's analogous to our semicircular canals. We have them so that we can sense if we're falling back to the right, if we're falling forward to the left, if we're rotating like this. And these semicircular canals sense angular velocity and rotation. So it's not as much that my head is turned in a sustained fashion to the right, so I'm looking to the right. It's more that action of when I turn my head to the right, that horizontal semicircular canal is really going to activate. Now you have another part of your inner ear where you have the utricle and the saccule, those are their names, and these sense basically gravitational forces, they sense linear forces. So if you are going up in an elevator, then different parts of your inner ear, namely the saccula, is going to activate when you go up in that elevator, because it's like calcium carbonate crystals on a jelly layer. And so when you go up in the elevator, it depresses that gel-like substance, and then that tells your inner ear you're going up. So that's basically the diagram of the inner ear. So when we are at rest, our brain actually has a hard time differentiating if my head is tilted to the right, or am I translating to the right? And I know that probably looks like to the left for all of you, so I can do it backwards. So is your head tilted to the right, or is your head translating to the right? And that's called tilt versus translation. And for the brain to figure this out, it's actually fairly complicated, because it has to compute what's going on in the semicircular canals when your head is like this versus what's happening with the quote-unquote autoconia involving the utricular and the saccular macula. Big words, just meaning think sand on jelly for one part of your inner ear that senses kind of the gravitational pull, and then you have the semicircular canals sensing angular rotation. Well, all these signals are, is this okay thus far, Kathy, or a little too much?
Yeah, I think we're okay.
Okay.
I can't see what you're doing, but
right.
Sounds like to me you're putting it all together.
Okay. So then these signals from your semicircular canals, your neck, your autoconias, I'm going to term them autoconial mechanism. Basically, this all has to go into your cerebellum, and your cerebellum has to compute where you are. Your cerebellum has to know where your head is relative to your neck. Your cerebellum has to know where your head is relative to your thorax, your body, your feet. There's all these things called reference frames. But all this computation is done mainly in the cerebellum and the brainstem. Now, if there's an imbalance in how your cerebellum is processing that, that can lead to somebody feeling like they're rocking. So they can feel like they're rocking back and forth if there's an asymmetry in this calculation. And velocity storage, to now take a breath, okay, hopefully everybody has that. Velocity storage is a really interesting thing. So talking about the semicircular canals, let's say I spin myself to the right. If I spin myself to the right, my semicircular canal is only going to discharge for about 6 seconds. So I'm rotating to the right. Fluid is moving in the semicircular canal. Think of water in a water bottle, you know, like you move the water bottle and the water lags behind. That's kind of how it works in the semicircular canal. So you turn to the right, and the water is only going to deflect the sensor in your semicircular canal for like 6 seconds. However, the signal in your brainstem, or my brainstem, for me turning, even if I just keep turning, it's only 6 seconds that the inner ear is going to discharge. If I keep turning, then that signal is going to be perpetuated for like 30 seconds. That's called velocity storage. And a lot of that velocity storage mechanism is done deep in the cerebellum. I can't even point to it because the brainstem is covering it up. For everybody on Facebook, everybody on YouTube, but it's called the nodulus and the uvula. Those are the primary areas that encode velocity storage. So researchers relative to MdDS have figured out that there's an asymmetry in velocity storage for patients with Debarquement Syndrome, meaning their velocity storage mechanism is asymmetrical in thinking that maybe they think they're falling forward to the right. Or yeah, for me, it's forward to the right. You get it. Falling forward one direction versus another. And so just as if I were to spin right and left, and maybe my velocity storage sends signals for 32 seconds on the right and 28 seconds on the left, that can be a problem. But it particularly becomes a problem for MdDS patients because now you've gone on a boat, you're on a plane, you're driving across country, you're floating in the water, or you're doing absolutely nothing, and there's an asymmetry in this mechanism. So now the brain, rather than knowing where you're at, your brain doesn't know where you're at, and your brain thinks you're over here. And so it starts pulling you this direction. Starts pulling you the opposite direction. Now you have this perpetual signal that you're rocking back and forth. And that's what creates the misery associated with MdDS. Does that kind of make sense, Kathy?
Yes, it does.
Okay, good.
And we know we talked about the brain and how it figures out where we're at or how it takes us where we're supposed to go. Even when we talk about older folks when they fall, they always try to fall backwards, or they say they fall backwards, but the brain is compensating for what it's feeling.
Right.
So, yeah, the brain, I mean, I guess maybe we could think of it as almost true north. Mm-hmm. For if we were talking about direction. So that's always our true north, to be standing straight. So right. We're messing it up when we have this hiccup or abnormality that's making this asymmetry in the brain.
I love that. That's perfect. True north. I really like that analogy. Yeah, because our brain has to know true north, referring to, you know, like what is actually what is the direction. Your brain has to know where you're at. And so often with patients who have chronic dizziness or MdDS or vertigo or things like Parkinson's, where people are having trouble walking and they can't move because their feet won't move, all of these things lots of times relate to the brain not knowing where we are. Where is true north? The brain loses sight of that. And when you start looking at the brain like a computer, as I've said in other broadcasts, I think the brain is probably the most phenomenal computer that's ever been designed to date. Because when you try and actually put together all these systems, think if you were just an eyeball. If you're an eyeball, all you know is that you're an eyeball. And all you know is the visual information coming in. That's the center of your universe. But the brain has to take what the eyeballs universe with your inner ears universe with your neck's universe, because your neck has tons of joints, believe it or not, or tons of nerves in the joints. So your receptor density for things like feeling muscles stretching or joints moving, like most of it is right here in your neck, believe it or not. I can't remember the exact statistics, but it's significantly higher in your neck. So now your brain has to take all these universes of signals and basically create an ensemble for where you are. And once these systems starts start failing. Or if your cerebellum isn't healthy, particularly down here, then your cerebellum can't process things. So it's like your computer has a virus, and now with that virus, it can't do its job, and the system slows down. And if it's your cerebellum, you start to get dizzy, and you feel like you're moving.
Okay, makes very good sense.
Okay.
All right, so are there potential treatments? Things I read online didn't look too hopeful, but I'm guessing you know some other stuff.
Yeah, so relative to treatments online, or that are being read about online, basically...
Well, I read that basically the only thing anybody was trying was like motion sickness things that didn't do much. You made allusions to meds, physical therapy, and magnetic stimulation. So I'm guessing you have some ideas of some better stuff than just trying seasickness. So.
Right. Yeah, exactly. So treatments online, or treatments that are being talked about online for MdDS patients, include the following. You can take antidepressants. You can take drugs like Xanax. I'm not prescribing those, but those are talked about in the literature as being helpful. Why? Because if you feel like you're rocking all the time, it's incredibly distressing, and those medications seem to help. Other possible therapies being explored include RTMS, which is basically transcranial magnetic stimulation, where they put a huge magnet on different parts of the brain. They found if they put a magnet on the cerebellum, in the middle part of the cerebellum where the nodules and the uvula are, people tend to feel better. So that's kind of interesting. And then they've also done studies on what's referred to as optokinetic stimulation. So if you're driving down the freeway, and okay, so you're a passenger and you look out to your right and you're looking at fields and you see all the fields passing by you, or you see all the telephone poles passing by you, that's called velocity storage. So not velocity storage, that's called optokinetic stimulation. And it's when the visual world is moving past us. So because MdDS patients have a lot of motion and visual sensitivity, researchers started using optokinetic stimulations in opposite direction of where they thought they were moving to help them, if that makes sense. So if you feel that you're bobbing over to the left-hand side, these researchers out of Mount Sinai in New York started, I think his name is Dr. Day, I may be mispronouncing it, D-A-I, however you pronounce that. So he started using optokinetic stimulations where people are looking at basically a drum with a bunch of like fence slats in them or vertical lines going the opposite direction of where they thought they were moving. Or he'd do some other tests and he'd figure out which direction he'd go. And at the same time, he would have someone take their head and tilt it in what's referred to as the roll plane, and he would tilt their head at the frequency basically that they thought they were moving, or that other MdDS patients feel that they're bobbing back and forth. And it seems to be around 0.165 hertz for anybody who cares, who has a metronome, or 0.167 hertz, which is about the frequency that will make people vomit. So when you're on a boat, Kathy, as we're talking about, and you're rocking back and forth, well, there's a certain frequency of rocking that seems to make us most nauseous. And so that's what he did. And that seems to produce benefit in a certain percentage of patients. In one study, I think it was like 48% of those who had MdDS coming off a boat, a car, or a plane. And another study, I think it was around 70 some odd percent, and even the spontaneous forms of MdDS improved as well. So that can be effective, but the question becomes, will you have to keep doing it? Sometimes no, sometimes yes. And you may feel kind of sick while you're doing that. So this is a recalibration, so to speak, for the velocity storage mechanism. My argument would be, okay, if it fixes it, fantastic. If it doesn't fix it, then you really want to be thinking maybe you have an autoimmune problem affecting your cerebellum.
Okay.
Yeah.
Is this anything, having gone through a program with you and working on vertigo and doing the brain restimulation and that sort of stuff, the exercises that you do, does that have any effect on the MdDS? Yeah,
so we've worked with MdDS. I can't cite a research article per se, but I've worked with a lot of MdDS patients. So talking about Dr. Day's work, you know, I think it's pretty cool. I think it's novel what he thought to do there. But I would also say there are other ways to skin the cat, so to speak. So in the functional neurology world, we use specific eye exercises that are trying to activate parts of your nodulus in your uvula that are not working correctly. So there are specific eye exercises that can do that, or activate other middle parts of your cerebellum that may be weak. Because for all intents and purposes, I think most of you can appreciate this. You feel like you're bobbing back and forth, and we talk about your brain's perception that maybe your brain thinks you're falling forward to the right, so you're being pulled back to the left. Well, it's kind of like a car that's out of alignment. And we can do specific eye exercises that strengthen the middle part of the cerebellum, so maybe we can right the car, so to speak. So you're driving straight ahead. And that's what we've done with patients, while also trying to calm down immune inflammation, so that hopefully their immune system isn't attacking their cerebellum as much. And we've had a lot of success with people that we feel would respond to what we do. That's what I can say. So yes, we've worked with MdDS.
Okay, and so basically when you're doing that, you're taking care of that asymmetric problem that's happening in there.
Yeah, exactly. Exactly. It's just a different way to do it. Yeah.
Okay. All right. Almost like a manual override.
Yeah.
Because you do have to do the exercises, and it is time consuming, and it does feel a little weird when you're doing it.
Right.
But I think it's extremely cool, and since I went through the vertigo part of it, I know that it actually works. So that re-stimulating those parts of the brain and kind of waking them up, and as we always say, kind of in functional stuff, kind of putting everything back in balance, which would get us back to that true north we were talking about. Right.
Yes. Exactly.
Okay. All right.
All right.
And you know, my pet peeve that says this thing attacks more women than men.
Right.
And more migraine patients than men, which in my knowledge, more women have migraines than men again. So is there a hormonal component anywhere in there?
Oh, I'm so glad you asked. Yeah, I skipped over that. So yeah, it's interesting that they found that women who have MdDS, who then become pregnant, their MdDS like goes away or gets a lot better when they're pregnant. And they're thinking that estrogen and progesterone, when higher, seem to help get rid of these symptoms. Why is that going on? Maybe it's shifting the immune system. Maybe, hormones affect the brain, so it might be affecting the frontal lobes differently, which then affect the cerebellum. So I can only surmise, but yeah, there is a hormonal connection. And thanks for bringing that up. I forgot that.
What do we think that could be when they're actually, say, on the boat or in the airplane or in the car? Is there a component there that female hormones are more susceptible, or that they can turn this on more? Or I don't know. I'm fishing here.
No, it's a good question, and I would.
The right term.
The only thing I can say from my clinical experience is that most of MdDS patients, not all, but most MdDS patients I've seen have some level of autoimmunity to the thyroid that's probably too high. So we had someone say, what do we do to fix this? I would say really get your immune counts to your thyroid checked. Thyroid antibodies is what they're termed. I would also have other immune cells checked to the cerebellum, things like GAD antibodies. Gluten antibodies. Gluten, Kathy and I did a broadcast on gluten ataxia. Gluten is one of the biggest offenders to your cerebellum. So having those things checked, I think, are really important. And to answer your question about the female preponderance here, Kathy, I would say, at least in part, it might be because things like Hashimoto's are more common in women, and antibodies to your thyroid, immune cells to your thyroid, think of them as immune missiles, can attack the cerebellum. So I think that's what basically makes some individuals more predisposed for something like this to occur. Yeah.
Okay. I'm just thinking of my history, and in the old days when they sailed, and seamen never wanted a woman on the boat.
Oh, interesting.
She was considered bad luck.
I didn't know that.
And I'm guessing maybe because they always said once the guys got their sea legs, they were good. But females, there were a lot of women who perished on trips across oceans and stuff because they suffered so badly with seasickness and that sort of thing. So I don't know. In Meniere's disease, is that prevalently more women also?
Oh, I'd have to look at that. So what we can say with Meniere's is that there's a huge correlation with Hashimoto's and Meniere's. I hate to keep saying it, but I mean, like 57% of Meniere's patients have been found to have gluten allergies. 57%, like just a simple gluten allergy, 57%. That's kind of significant. And there's other studies that basically, I think it was around half of Meniere's patients either had Hashimoto's or they had autoimmune problems. Those are conditions that tend to be more common in women. So I would say, yeah, Meniere's might be more common in women, but I can't say for sure. But this is a little different because with Meniere's, what happens is when I was talking about the inner ear, you have fluid in your inner ear. So your cochlea, which looks like a conch shell that you would see on the beach, and then the vestibular apparatus with your semicircular canals, and then the autoconial mechanisms. Basically, there's fluid all through there. And so if that fluid doesn't drain, the inner ear swells. And when it swells, people get vertigo, room spins around them. They start to have ringing in their ear and pressure. And then through time, these organs in the inner ear start to die. So they start to lose vestibular function. They start to lose hearing. Yeah.
Okay.
Mm-hmm.
So from what we've talked about, if you've been on say it can be spontaneous, but
mm-hmm.
also if you've been on a trip or one of these things and you continue to have these feelings, then you definitely need to get in to see someone. And the way I read it online was it talked about, this isn't diagnosed very easily or
mm-hmm.
very frequently.
Mm-hmm. Yeah, it's not a really common condition, but I think when you start looking for it and when you recognize the spontaneous form of it, you're going to see more of it. The problem is that in the dizziness world, these disorders lots of times are nebulous. Someone comes in and they say, I don't know, I'm just dizzy. These conditions are hard to describe. So I'm dizzy. I don't know. What does it feel like? Is the room spinning around you? No. I just feel like I'm moving. Well, there's a lot of people with those symptoms, and it can be a number of different things. You can have a brain tumor. You can have a brain bleed. You may have a tumor growing on your vestibular nerve. You may have BPPV in the horizontal form. So BPPV, benign paroxysmal positional vertigo. You heard me talk about the autoconia, the sand stuff on the jelly. Well, those can dislodge and go into your inner ear. And most commonly, doctors are thinking it's going to affect your posterior semicircular canal. So when you lay down, the room is going to spin. But there's this horizontal variant, which we're finding is more and more common, particularly in the elderly. And so you may be just turning your head, and all of a sudden you're just, I'm dizzy. You're not going to necessarily have vertigo, but you're going to be dizzy because you have like too much sand in the horizontal canal. So that has to be figured out. Or do you have something like MdDS, or is your cerebellum just not? So relative to the question, because this is the listener who requested this, I think, basically, what can we do to fix this, or what do we need to do to work on it to help it? I would say find a doctor who knows what I'm talking about relative to Dr. Day's work. That's a great place to start. And if you have trouble finding that doctor, you can consult with us. Also, I would say look into this autoimmune issue to the thyroid, gluten, the cerebellum, because that may be the answer as to why the cerebellum is not processing things correctly. And I also say we've had early experience where we're doing MRIs where we can assess the volume of the cerebellum. And I've seen in some MdDS patients decrease volume in the cerebellum. And if you can reduce the inflammation, I'm thinking it's possible that you can actually improve volume in the cerebellum. So I'm thinking that.
Inflammation is just a pain in the butt.
It's the American way right now. It seems like we're all inflamed. Yeah.
And it does seem to be a chronic thing, and there are different ways to take care of it. Like you said, gluten's a good place to start. So I'm interested to see what your results are on some of these other people with the MdDS. I think this is interesting. The magnet thing is interesting, but
mm-hmm.
I think you're onto something with the autoimmune, and then I said with the eye exercises that you do to stimulate the brain and get it back to where it needs to be is we know something that works, mm-hmm. and we've seen it time and again. So I would say that would be some hope for some of these folks.
I agree. It's exciting stuff. Yeah, when you see what's going on here. Well, I think that pretty well covers it. Anything else, Kathy?
No, I think that's got it.
Okay, so I think we answered all the questions. Thank you, everybody, for joining. You can go back and watch this on Facebook, or we also recorded it live on YouTube. So that's going to be available in the next couple minutes. And we'll be back next week. Any topics you want us to discuss, let us know, and we'll go into it. So have a great day, and we'll talk to you soon. One last thing. So one question just popped up where they would say they'd love to know the eye exercises. All I can say is they have to be specific for that individual. So I can't just say, well, do this or do this. It has to be specific for your condition and what is found in the neurological exam. So
yeah, Dr. Gates has a big neurological exam that he goes through and prints out this huge big thing that shows what's going on exactly with your eyes, your brain, everything that's there. So then he knows how to make the unique plan just for you,
right,
the individual, so that you've got what you need and the exercises that will stimulate your brain, because definitely no two cases are the same.
Completely. And that's where we use the video nystagmography goggles and the recording system, because we can really see. It's interesting with MdDS patients, lots of times when they're in the dark, you'll see the eyes moving opposite the direction that they think they're bobbing. And so, yeah, lots of times I give MdDS patients exercises, and then it may not work. It may be too much. So we have to refine them. So that's where not meaning to dodge the question, but that's the honest answer. So.
Well, that is the one thing that I've noticed, is that people don't think anything like that can be that powerful.
Right, because it looks so simple.
Some of those exercises, they seem very simple and mundane, but what it's doing between your eye and your brain is pretty impressive. So, yeah, sometimes you got to back off or do something different or whatever, but it's impressive that you can turn some things back on that have been dormant or not actually working the way they're supposed to. Right.
I would agree. I would very much agree. And then our last question was about the Epley maneuver. The Epley maneuver is for people who have BPPV in their posterior canal. Now, to answer the question, sometimes the Epley maneuver can be used to reposition or get somebody to better know where their head is relative to their neck. So the Epley maneuver is now being used by some to not just treat, the autoconia that have dislodged the sand in the canal, but it can be used to help the brain reconfigure where we're at. So that's what I'd say there. So I think we hit it. I think this is good. Thank you, Kathy.
Okay, thank you, Dr. Gates.
Yeah, and we'll see you all next week. Have a good weekend. Let's see here. And that.